Advocate Cancer panel. We are so excited to have everyone here, and we're just really excited about this initiative, about what we could possibly do with this information. I know for myself and Cynthia and Sue, everyone at the Cancer Support Center, really, when we first got involved with this project, we were just so disheartened by the mortality rates that we were seeing right in our backyard. And so we are just empowered and impassioned and emboldened to really just try and do something about this. And this is step one. So thank you all so much for being here and being part of that initiative with us. We have some amazing presenters with us this evening that I'll be formally introducing as we go along. I'm also going to be starting a poll for everybody to share if you feel like you can answer those questions, and just trying to do that at the same time, and that's not working. So I will get the polls up at some point tonight, and if anybody has any questions throughout the presentation, please go ahead and throw those in the chat box, and then we will certainly have time to answer them at the end. I did get some questions come in via email, so I'll make sure that we answer those as well. And without further ado, we're going to kick it off with Dr. Ramona Burress. I'm going to pull up my screen share again to introduce her to you all. Dr. Ramona Burress is a Chicago native, mother of 3, clinical pharmacist, and a metastatic breast cancer patient herself. Ramona works as a vaccines and infectious disease scientist for Johnson & Johnson, emphasizing clinical trial diversity for patients diagnosed with cancer, HIV, and other health conditions. Her experience as a healthcare provider and patient offers a unique perspective to her health equity advocacy efforts. Very active in the community, Ramona also serves as a CPS Local School Council Chair of Kenwood Academy and maintains board positions with leaders of literacy, personal PAC, and Chicago Children's Advocacy Center. Dr. Ramona, thank you so much for being here. I'm going to go ahead and turn the screen share over to you. I'll find you here and pin your video.
Well, thank you. So I actually didn't have any visuals prepared for this evening, but I did want to start off by thanking you for having me on this call. The Cancer Support Center, it's something that I think is an important asset for folks to have as they go through the journey of cancer, but I really want my talk today to not only be about my journey in particular, but how we need to galvanize our communities so that we can be more reactive and proactive in this space. So I am 41 now. But I was initially diagnosed with breast cancer at the age of 34 in the midst of going through a divorce, separating from my husband of 13, 14 years with 3 kids, pharmacist trying to move rapidly through my professional career, getting promotions after promotions, working 60-hour weeks, what have you. And I felt a lump in my breast and I ignored it for a second, but after a certain point, it just didn't go away. So I called my primary care physician over the phone. I'm like, hey, I had this lump. I'm concerned about it. She had just seen me a few months earlier for my annual exam, and she knew I was going through a divorce and all over the place, right? Because type A, you know, just doing too much as a woman. She said, you know, Ramona, let's just wait and see. You know, you got so much going on. I just saw you a few months ago. I don't think it's anything. Then a week later, another phone call because that lump started hurting a little bit. And same type of conversation, let's just wait and see, no sense of urgency. And then I called a third time. I'm like, hey, this is impeding with my daily activities. The breast that had the cancer was my left breast and I'm left-handed. So the pain that emitted from that one area was affecting, again, my daily activities. So I was finally granted an appointment to come in and see my primary care provider. And in that setting, I was told that, I don't think that it's cancer, but because you have Blue Cross, let me send you for, let me put in a referral for you to have a mammogram. Because again, 34, no obvious risk factors. So I had no family history of any type of cancers, let alone breast cancer, was not a smoker, was physically active in the gym 6 days a week, was not on any hormonal birth controls, was not obese at the time, now I am. But none of the risk factors that are usually associated with, higher risk of breast cancer occurrence. So lo and behold, I got that mammogram because of my Blue Cross. Woohoo! And it was determined to be stage 1 cancer with imaging. At the same time, Angelina Jolie was going through her personal battle with cancer. And I remember her being interviewed by Barbara Walters or something, and she said she had a radical double mastectomy. So in my mind, the power of influence of social media and celebrities, when it came time for me to decide what my treatment was going to be, I elected to get the double mastectomy because, again, being younger, there was a risk of having an occurrence in the breast that remained if I chose not to have it surgically removed. But again, Angelina Jolie, her story gave me, strength to kind of get through it. And once I kind of sat down with my oncologist to determine, like, hey, am I going to die from this? And was given a no. I was quite happy to have a new set of boobs, right? Like, there's an upside to everything. Going through a divorce, going to be on a dating scene, so new boobs, and perky, boobs too, were upside. So I decided to do that. So again, still diagnosed with stage 1 at that point. And then when I went to have a double mastectomy done, that's when it was determined to be stage 2. But I went through chemo and everything, returned to work too early because, again, going through divorce and now being a sole provider of a household full of 3 kids and trying to live my best, bad, and bougie life in Hyde Park, an area I couldn't afford, and kids in private school and all that, I went back to work too quickly, right? Because, again, there are so many other things outside of just a person's health journey that determines, how they're going to be a participant in their own health, I guess, journey. And so for me professionally, as a clinical pharmacist, I worked in the infectious disease state and typically HIV. So I've seen, the marginalization of patients in that space, and I was always their advocate. But I totally found that when I became the patient, all my scientific reasoning went out the window, all my advocacy, stuff kind of just took a second seat because I didn't prioritize self. So long story short, went back to work, was supposedly cured for cancer. And my oncologist at the time recommended that I get a hysterectomy because my cancer was determined to be HER2 positive. So it meant that my hormones were feeding the tumors. And again, being 34, going through a divorce, potential for relationships, I said no to the hysterectomy because I didn't want to, I already felt like Frankenstein at that point, having these new boobs. But the hysterectomy, it was just too much of a blow, too much at once. So I said no. And I think that conversation with my oncologist, me not taking his advice, kind of shifted our relationship. Again, even though I'm a healthcare provider, it was still irrational thinking for someone who is, scientific space. But Ramona, the person, Ramona, the woman, I didn't want it. It made all the sense in the world, but I chose not to go that route. So long story short, a year after that, I was in bed with my youngest daughter, and we were just fooling around, and she elbowed me in my mouth, and she chipped out my front tooth. So I went to my dentist to get fitted for an implant or whatever he was going to do, but he needed a fancy CT machine to fit me for a jaw structure or whatever. And he saw some opaqueness in that imaging and told me to go back to my oncologist. And that's how I found out that my cancer had metastasized. So it's currently in my jaw and in my hip bone. But all that to say, I was still being routinely monitored by my oncology team, and I still use them to this day, still have my same primary care doctor. But it's just amazing how our healthcare system is like 15 minutes, boom, 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 in and out, that we've kind of really lost that relationship that patients should have with their providers. And so when I talk about disparities, whether it's in the breast cancer space, cardiology space, I do make a big push for us to promote healthcare providers who look like the patients they serve, because there is a such thing as this cognitive dissonance, and there is a such thing as provider bias. That's really true. And I think if we kind of work at that to our resolutions to make rates of mortality better, that should be something that's included in the equation, is to encourage kids to come through the pipeline for professional careers, because we need more folks who represent the communities they serve. So I chose not to do chemo and radiation again because finances, right? Again, science background totally went out the window. I was thinking about my 3 kids and how we were going to survive as a family. But I found my own clinical trial. So because of my extensive research with clinical research, I knew where to go to find a trial that I could potentially be a part of. So I found one. It's been going great. I've surpass my expiration date that I was given once I was given that stage 4 diagnosis. So I am the face of metastatic breast cancer. But there's this image that is on the Cancer Support Center's website where it talks about their programming. It has like a quality of life symbol in the middle with a whole bunch of different branches coming off. So like one of the branches is nutrition. And so this is why I think Cancer Support Center is so great, because these are true issues of what folks are dealing with outside of just cancer itself. So nutrition, I love my Flamin' Hots, I love Coca-Cola, I love Starbucks, and I'm not going to deny myself, but I do know that nutrition is an important component for, you know, whatever disease state that we're looking at, because of chronic inflammation with sugars and processed foods. So we need to focus on that. Again, if I'm talking to an audience of women, we need to put ourselves first, and again, focus on that before we even get a diagnosis, whether it's high blood pressure or not. Then there was a section on the Cancer Support Center's website about body image. Body image is huge. Like, I never really tell folks, but I really had to fight with my reconstructive surgeon to keep my nipple on my right breast, which was not the cancerous breast. So on the left, the nipple had to be removed because it's one of the tumors was too close. So, you know, they removed it, sewed it up, and then tattooed me a new areola, and it looks functional, so I've heard. But I really had to fight to say, hey, if this right one is fine, like, let me just keep my nipple. Can I have my nipple, please? So body image is important. Also, from a transparency perspective, I have not been able to look at myself naked since having that reconstructive surgery. So I think that was done maybe in 2015, if my timeline is right. I feel like for me, you know, as we process things, that's something that's a non-negotiable for me. So I take showers in the dark because, you know, I just, if I saw what I looked like, I think that would be my breaking point, honestly. So, but because I'm dating, I haven't had any complaints. So, you know, it's quite interesting, again, how everybody's story is individual, but you know, again, I just like to share my transparency with you guys. So then with that, counseling was one of the programs that's on the website as well too. So you see Ramona needs some counseling because she can't look at herself naked, right? But also like stress management, because again, if we talk about chronic inflammation, as women, we're usually holding down our household, taking care of our kids, our spouses, our parents, our siblings. And so with that stress comes just inflammation. So again, if it's diabetes, if it's cardiovascular risk, if it's cancer, it manifests itself in so many different ways. So I think we need to seek counseling, again, proactively, so that we can balance being a woman that has it all and does it all, because it truly does make an impact on our health outcomes. And one of the other things was fitness and physical wellness. I have recently started doing meditation. I found a playlist on my Apple Music that I love. I listen to throughout the day when folks are trying to stress me out. But more importantly, I hit the gym every morning. And I know that may sound kind of like weird, but I hit the gym so that I don't become fatigued throughout the day, because my job requires me to be cognitively spot on. And I've noticed that when I go to the gym, I can do it, have no breaks, and cognizance, because, you know, with the cancer treatment, with some of the drugs, cognition is a huge side effect. So going to the gym helps me to maintain my sense of self, but I got to get it done at least 6 days a week. And then education and networking, I think, was the last bullet that they had. But I love opportunities like this because we need to educate. But again, we need to be more proactive instead of reactive in the education. So, you know, whether it's our high schoolers, whether it's community health workers who are going out in the community and just talking about everything. Mental health right now with COVID is a huge issue. You know, so we need to galvanize as a community and really share this education so that if, heaven forbid, we do have a diagnosis, we can be an active partner in our healthcare journey, because it's only truly education that allows you to have that privilege. And we all deserve that right. But I think that's definitely something that enforces that to be something that's pretty constant and consistent in our healthcare delivery. But I think that's what were all the bullets. But that's my story, and there's so much that I omitted, you know, for the sake of time. But again, that's why I appreciate being on this call with Cancer Support Center, because yeah, cancer is just a one piece, but there are so many longitudinal side effects and sequela that comes with the cancer diagnosis, whether you're a survivor or whether you're a thriver or what have you, even if whether you're a caregiver. So thank you, Kathleen, for having me on this call. And I look forward to hearing from the rest of the panelists.
I'm so sorry. I had myself muted for a moment. Thank you so much, Dr. Burress, for being, again, to echo you, so transparent with yourself and your experience. You know, I don't know if you could see the comments that were coming in while you were speaking, but everyone was just so grateful for everything that you shared with them. And I just am so, I feel grateful again to just hear your story and for you to share that with us and this panel, because I think it just really demystifies what it looks like to be living with breast cancer. And so certainly I'm sure more folks will have questions for you as we move through the panel this evening. I'm going to turn us over to Dr. Rozell in just a moment. I'm going to share her bio in just 1 second. Oh, Dr. Shaina Rozell, welcome, welcome. Dr. Shaina Annette Rozell is a physician leader and a source of community pride for her family and peers in Chicago, Harvey, and Riverdale. From a young age, and thanks to the influence of her grandmother, Shaina knew that in medicine she would find a special opportunity to combine her abilities in science with her passion to serve others. After completing both her medical degree and public health training at Feinberg School of Medicine at Northwestern, she went on to continue her residency training in internal medicine at Mayo Clinic in Minnesota, and then went on to complete her fellowship training in hematology and oncology back at Northwestern, and is currently employed with the affiliated oncology group, where she is the education coordinator at Advocate Christ and South Suburban Hospital. She is also a founding board member of the Katherine E. Johnson STEM School for Girls, and over the course of her medical training has investigated multiple disease processes with a specific focus on gastrointestinal, lung, and breast malignancies. And I'm going to share a PowerPoint for Dr. Rozell. Give me 1 moment to switch PowerPoints over here.
I see patients here.
The beginning, and Dr. Rozell, just kind of let me know, or I will try and be intuitive as we move through here.
Hi,
and
everyone.
take it away.
Can you hear me? Oh, perfect. Hi, everyone. So thank you for that introduction. It's a pleasure to actually be here and to support this program. It's so funny, like I was just announced as our director of our cancer support center here at South Suburban, and I've been doing lots of interest in genetics and high-risk genetics at Advocate Christ. So I've been busy. So I am honored to actually take that time and discuss breast cancer, if you would allow me to, okay? So we're gonna discuss breast cancer prevention to treatment, and after our discussion, we can feel free to ask any questions. I am available. I think, can I forward the screen? I think, can you help me? Okay, here we go. Okay, so the first thing I wanna discuss, and usually when I'm discussing with my patients, is there are things that you can't change, okay? When you actually get breast cancer, there are things that you can't change, and there are things that you can change. So what are the things that you can't change? So 1, your gender. Women are more likely than men to actually get breast cancer. Age. Older women are more likely than younger women. So although we are seeing a rise in our younger patients, the majority of the patients are still older. As you get older, you are at a more increased risk of actually developing cancer. Your genes, okay? And so the main question I get when I see patients is they say, why did I get breast cancer? This does not run in my family. And the reality is that most of them, it doesn't run in your family. It's only about 5 to 10% of breast cancer cases, and they are thought to be hereditary. And that's BRCA1, BRCA2. There are a lot of other new genes that we're investigating, BARD1, PALB2, and that's exactly what I do in my clinic. It's how can we actually further investigate what types of genes may put us at risk or predispose us to other new cancers. And then the personal history of breast cancer. And so if you have a history of breast cancer, you're more prone to develop either a second cancer or a different type of cancer. So this is something that I am very strong in emphasizing in our patients who may have some risk factors such as smoking. And I have that discussion with them and say, hey, you've already had one cancer, you're more likely to actually have another. Next. So what is the role of genetic counseling? So this is something where we're identifying patients at risk for hereditary cancers. And this is one of my main interests. And why do we do that? Because one, it helps us decide what type of surgical decision. So if you do have that mutation, for instance, the BRC1 or 2, and we know that you have an increase, about a 90% increased risk of another breast cancer or even ovarian cancer. So this is, in these patients, I'm recommending either double mastectomy or oophorectomy. And so it's very important to know that up front. It also helps to identify risk to patients and families. I am an oncologist. I give chemotherapy. I don't like giving chemotherapy, and so my job is how can we actually prevent cancers? How can we prevent cancers from taking our loved ones? How can we prevent new cancers from developing? And so that is my number one passion is what can we do better? What can we discover? Another thing is we offer referral for screening, management, and support, and then participation in research studies and develop new treatments. So one of the things is we know that in patients who have BRCA1 and BRCA2 mutations, there are also new and novel medications for these patients that were not developed in previous years. And so these are things like PARP inhibitors. And so I'm always investigating. If my patients know who I am, I'm going to do some extra testing and analysis and look at their genes and see what we can do and what ways we can develop potential new treatment options. Next. So what are the non-modifiable risk factors? One is race. African Americans are more likely to die from breast cancer. And that's a big passion of mine and one of the reasons why I'm here in my own community. We see again that the numbers are there. You have a higher risk of cancers, higher risk of mortalities in our backyards, higher risk of delays of actually diagnosis, higher risk of treatment. One, because this is a more aggressive behaving cancer, and two, because patients are afraid of doctors that don't look like them. And so how can we break down that barrier? And I think for me, being an African American oncologist, which is a rarity, that I think that has been very helpful. Another thing is dense breast tissue, and I want to emphasize this is, usually patients are getting their mammograms and the mammogram comes back normal, right? But the mammogram says you have dense breast tissue. And what does that mean? That means that this mammogram cannot really see any hidden masses or any obscure masses. And so it is extremely important, and it's actually by law, to actually have an ultrasound. So if you see your report and you see something that says, oh my goodness, if you see something that says dense breast tissue, please advocate for yourself. Talk to your provider and say, I need to get an ultrasound. He says, why? I said, Dr. Rozell said, I need my ultrasound. No, just kidding. But no, I really need you guys to get that ultrasound because believe it or not, we're detecting more cancers. And I'd rather detect it at an earlier stage where we can actually do something about it than when something happens and, for instance, we're at stage 4 and we're not talking about necessarily a treatment cure. What about, go back.
Oh, sorry.
More menstrual cycles. This is a little bit vague. What we know and what we're finding out is there's slightly a higher risk if a woman started menstruation early or went through menopause late. And that really has something to do with the role of estrogen in the body. Next. All right. So what about semi-modifiable risk factors? So this is, again, some things that we're not necessarily sure about, and they may have, a role with too much estrogen in the body. So that's postmenopausal hormone therapy, recent use of hormonal contraceptives and birth control, not having children earlier, having them later in life after 30, and not breastfeeding. And so this is the issues with too many cells accumulating and kind of changing and developing into cancer. So what about our modifiable risk factors? Things that you can do. So physical activity, okay? More exercise decreases the risk. Too much weight, and that's because estrogen is also in our fat, can increase the risk, especially after menopause. And then alcohol use, too much alcohol also increases that risk. Go ahead. So what about prevention? So every woman can lower their risk for breast cancer by, again, focusing on achieving and maintaining a healthy weight. And this is not for everybody, but I'm big on this, and adopting a physically active lifestyle and limiting the alcohol use. Okay, here are the statistics as of 2019. As you can see, in males, the estimated new cases is prostate cancer, which are about 174,000, and breast is still the #1 cause in females, around 30% or 268,000. As we look here, deaths are actually, as far as the estimated deaths, in men, it's lung cancer, and also in females, it's lung cancer, but breast is #2. So again, I'd like to see that go further down the line, and I think we're improving, but we can still do better. So usually when I'm having a conversation with my patients and, you know, they're first newly diagnosed, I do have a long conversation with them, so I don't give the 15-minute conversation. I take that time with new patients, especially to make sure that they understand what is breast cancer. Let them know that there are different types of breast cancer. Everyone is different. Your story is not the same as your sister, your cousin, your Facebook friend. Please stop talking to them because there is a variation. And so I wanted to kind of go over a little bit about what's the difference. So there are two types of breast cancer. One is ductal and one is lobular. So ductal is the most common, usually around 60 to 70% of all cancers. And it usually starts again in the duct. So I can't point here. Do you see that? No. So you can see the breast, you see the nipple, and you see there are tons of ducts and lobules. And the lobule is where breast milk is made, okay? And the duct is where the breast milk goes through and before it goes out of the nipple. And so ductal carcinoma in situ means inside the duct, this cancer is developing. This is what was considered a stage 0. And this is about a 1 in 5 new breast cancers. And this is why your mammograms are extremely important, because it's at this stage that we actually can diagnose it. And this is early stage and it can be cured. What we don't want is for these cells to kind of leave the duct. You can see a normal duct over here and DCIS or ductal carcinoma in situ. What we don't want is these cells to leave or invade outside of the duct, and then it continues to grow until you actually can feel something. We don't want that. So that is the reason why I am a pusher for making sure that you actually get your mammograms. How can we prevent this earlier? So same thing here is lobular carcinoma in situ. So this is a little bit more rare, and this is the cancer that actually develops in the lobes, or these milk-producing glands of the ducts. Lobular carcinoma in situ is not considered a cancer, but it does increase your risk of invasive cancer later on. And so usually here when I have a patient, I am putting them on a medication to prevent progression to an invasive cancer. Okay, so let's talk about invasive ductal carcinoma. So this is the more common, as I said, it's about 8 of 10 invasive breast cancers. So usually I'm quoting 60 to 80%. So again, it starts in a line that's in the duct, and then it invades or breaks through the duct and begins to invade surrounding breast tissue. So it continues to grow and grow until you actually can feel something. So invasive lobular carcinoma, as I said, again, it starts in the milk-producing glands, and like ductal carcinoma, it can invade into the surrounding tissue. So that is a little bit more rare, about the 15 or 20%, and it can involve more of the breast than the ductal. Okay, good. So how do we diagnose breast cancer? So mammograms. So mammograms, so there's 2 different types. There's a screening mammogram. So what is the role of a screening mammogram? This is what you're doing yearly with your primary care doctor. So it helps identify breast cancer earlier in its life cycle and before it spreads. And if I can say this, and I guess this is our Breast Cancer Awareness Month, please make sure you're getting your mammograms. Please make sure your family members are getting your mammograms, because again, I do not like to give chemotherapy. If I can identify it earlier and it's easier to treat, there's a better chance of being cured. There are different ways where we do screening mammograms. And so one, breast cancer screening is done with a mammogram. And then in patients, again, that I see in my genetics clinic or high risk, in those times, I'm doing a breast MRI. Okay, This is a picture of the mammogram. Most people hate it. Why? Because you are pressing the breast and between two plates and you're flattening it. And this is just a kind of a picture in showing it. So what are the guidelines? So typically women ages 45 to 54 should have a screening mammogram every year. And then they're saying ages 55 plus should have biannual. I still recommend annual mammograms. I even my older patients, if they are actually functional and fit, I think 80 is the new 50. No. Then if they are still thriving, then I am still recommending mammograms. And why is that? That's because you can still detect cancers at an older age. The older you get, you're still at more risk. And so I still recommend them. All right. So what happens if you have an abnormal mammogram? So then you are referred and you have what's called a diagnostic. So a diagnostic mammogram is really just looking at a mammogram with more pictures, and you're getting a better image. And then sometimes they refer you to get an ultrasound. So if they see some fluid or a cyst, it is a better picture to use a sound wave to create a picture. An MRI is a little bit different. It is usually in high-risk patients, and it kind of helps me determine the actual size of the cancer. And then we do a biopsy, which is really a needle that goes right into the breast tissue, and it tells me or gives me an answer as to if this is a cancer or if this is not a cancer. Okay, so then you see a surgeon. I'm not a surgeon, so I'm just gonna briefly touch on this. But when I'm having these discussions with my patients, the question is, whether to do what's called a breast conserving surgery or a lumpectomy or a mastectomy, which is removal of the entire breast. And there's various reasons on whether to do one or not. For instance, if you are a person who is high risk or you have a gene that predisposes you to actually having breast cancer or even in the other breast, then I would recommend a mastectomy. For instance, if this is a large cancer, where if I've tried to cut the breast and I would not conserve the image or the architecture of the breast, then that's someone I also probably would recommend a mastectomy. If there are 4 or 5 lesions all over the breast or areas, there's no way I can just take out different spots in the breast. And those patients, again, it's something where I would recommend a mastectomy. And then sometimes it's patient preference. And we call that also the Angelina Jolie effect. Then you have, again, a lumpectomy. With a lumpectomy, it's different. It also has a lower risk, for instance, of lymphedema. 2, it requires radiation because you want to prevent any cancer coming back to that same spot. And again, usually it's a more early stage. And so lymph node surgery. So what are the lymph nodes? I usually give the metaphor of the lymph nodes like a secondary river in the body. So it's a drainage system in the body, and it's the first place where cancer spreads before it goes to other parts of the body. So usually we do what's called a sentinel lymph node, and that's where they're injecting dye and they're looking at the first place where cancer can spread. And that helps to determine what the risk is of it going to other places. Prior to 2005, they did what was called an axillary lymph node dissection, and that was where they removed at least 20 or more lymph nodes, and that was pretty torturous. I mean, patients had much more risk of lymphedema, much more risk of infections, seromas, which is a fluid collection, and then they had much more issues with pain or neuropathy in that area. So instead, now we're doing sentinel lymph node biopsies. When they did the studies and they said, hey, the mortality rate is exactly the same. And so if the sentinel lymph node is positive, meaning that one area, if that's positive, then that would recommend, that would indicate that we would need to actually do more dissection. Next. So this is an example. So you can see here's your tumor, and then they inject this radioactive substance of dye, and then it goes and it drains, you can do your pointer, to these lymph nodes. In the first place, which is the sentinel lymph node, that the dye goes to is where they actually remove and they test. And if it's positive, then they would actually take out more lymph nodes. And if it's negative, they can say, oh, the likelihood that it's anywhere else is low. Okay, so here is the evolution of treatment. You can see in the 5-year survival rate of, and there's a lot of questions here, I'm gonna answer them. 5-year survival rate for US women. So before, you can look at 1975, it was about a 75% rate of 5-year survival. In 2008, it went up to 90.6, and now it's roughly about 95%. So, and it really also depends on the stage. You can keep going. Okay, so many patients come in, and I am an oncologist, so I give chemotherapy. But I also need patients to understand that I just don't give chemotherapy, I give targeted therapy. And people come in and they say, oh, I don't want chemotherapy. And I'm not offering that all the time. So what is the role of chemotherapy? So chemotherapy kills any fast cell that's dividing, okay? And that is the reason why you have side effects, okay? What are these side effects? Any fast dividing cell, that is what chemotherapy targets. It does not distinguish between cancer cells and non-cancer cells. It says, you're a fast growing dividing cell, I'm gonna kill you. So that is the reason why people lose their hair. That is why people have issues with their nails. That is the reason why people may have a little bit of nausea, because the lining of the throat is a fast dividing cell. But that is also the reason why your hair recovers. Okay, so I wanted to emphasize that. Where in contrast, you have what's considered targeted therapies, and these only attack cancer cells. So you don't have as much of the side effects of chemotherapy. And there are many times where I'm offering these things, such as if you're HER2 positive, I give HER2 directed therapy. Chemo is not stupid from leukemia. I'm just kidding. So when do we give chemotherapy? Okay. So chemotherapy has a role and a place. So one, we can do it after surgery, okay? And that is considered adjuvant chemotherapy. And that means I'm giving chemotherapy usually after surgery, go back, or before surgery. So say, for instance, I have a patient that comes in with a 12 to 13 centimeter mass. She's in pain. This is huge. That's a grapefruit, okay? And they are in a lot of pain. Well, I can give chemotherapy first to shrink it down, to make life a little bit more tolerable, and to actually see if there's a response, okay? How? It's given through IV, and that is through a port, or what's considered a PICC line. So what's the difference between targeted therapies? There's a major difference. So targeted therapies, one of them is called HER2. So HER2, for instance, is a protein that is expressed on cancer cells. And my goodness, this is one of the worst proteins ever that can be expressed on the cancer. Patients' cancers were growing extremely fast and spreading all over the place. In 2 weeks, they were stage 4, okay? And so with these medications that block the HER2, we made a dramatic improvement in, one, the survival of these patients and the morbidity. Same thing with estrogen and progesterone positive cancers. So these are cancer cells, they have receptors that attach to estrogen, which helps them grow. And so a lot of times in these patients who have these positive or estrogen positive cancers, I don't necessarily recommend chemotherapy. I actually am recommending a pill that blocks the hormones. And so it is important, you know, when you are talking with your doctor or your oncologist, that you actually are aware and you know what type of cancer you have. Do you have a HER2 positive, estrogen positive, progesterone positive cancer? Is it a HER2 negative cancer? Because they behave differently, number one. The treatments are different. And it's better to know about you, because again, you look at another person, they talk about whether they got tamoxifen or anastrozole. That's different than that may be different than you, okay? And then as I mentioned earlier, the BRCA gene mutation, there are new developments and targeted therapies that keep this cancer cell from repairing itself. Okay, so what about triple negative breast cancer? So this is a passion of mine. I just lost my aunt in January to triple negative breast cancer, okay, 47. And, you know, so this is a very aggressive cancer. We don't have hormones. This is a higher incidence in young women, higher incidence in African-American women, very aggressively behaving cancer. And as you can see here, these are just the percentages of the African-American versus the European-American counterparts. We are learning and doing better with our treatment strategies. Now we have the invention of immunotherapy for triple negative breast cancers, but again, we still need to make some more improvement in this triple negative population. So what is the role of radiation oncology? So say for instance, you've done your chemotherapy, you've done your surgery, now you've gotten radiation, okay? And what is radiation? So radiation is really destroying cancer locally, right at the breast, okay? So when do we use this? So in a person who's actually had, for instance, a lumpectomy, you want to prevent that cancer from coming right back to that spot. After a mastectomy, if the cancer was pretty large, for instance, if there's lymph nodes, you want to actually make sure that this cancer doesn't spread. And then what if the cancer has spread to other parts of the body? So say, for instance, Ramona had talked about in the bone, okay, and she was having pain. I actually would recommend, if there's some pain, that you actually do a little radiation to zap that area to make Ramona or any other patient feel better. So there are different types. There's external beam and internal beam. I'm not going to go over all that. Okay, so probably in the last maybe 10 years or so, we developed this, what's called a gene expression test. There's the Oncotype and the Mammaprit. And these are only in hormone positive cancers, okay? So it looks at your genes, your tumor specifically, and it tells you how likely are you to recur? What is the likelihood that that cancer is going to come back? What is the likelihood that that cancer is going to spread? And if that test generates a higher score, then I would say, let's get chemotherapy, because I want to lower that risk as much as possible. But if that risk is low, I do not recommend chemotherapy. So I want to emphasize to patients and to everyone out there in the community that I do not always recommend chemotherapy. I'm an oncologist, but I don't. And if you are HER2 positive, okay, you're not going to get, you're not just going to do a hormone pill, because I need to attack the HER2. If you are estrogen negative, you're not going to get this. That should have said only applies to estrogen positive tumor, sorry. If you are estrogen negative, you're not going to get this, because again, this is a more aggressively behaving behaving cancer. So what about the new treatments? Immunotherapy. So I know you've seen the new sexiness on TV, and that's what immunotherapy such as Tecentriq, Keytruda, nivolumab, or Opdivo. And what is the role of immunotherapy? So it uses the immune system to attack cancer cells, which I think it's fantastic, and it does a great job, and it provides new opportunity for us in so many different cancer types. But in March of 2019, so I'm telling you guys, it's fairly new. Go back. Fairly new when we're talking about breast cancer. They granted approval of atezolizumab or Tecentriq in combination with chemotherapy, who had locally advanced, so these are patients stage 3 or who could not get surgery, or stage 4 triple negative breast cancer. So remember, triple negative are more aggressive cancers, and all we had was chemotherapy. And so now we're using this as a way to actually extend their life, and we've done a much better job than previously. And then again, clinical trials. So I'm a big proponent of clinical trials, looking at different ways to kind of help prolong life. I'm all for it. I am always trying to discover something new, because that is how all of our medications have been developed. Next. So in summary, I talked about some of the risk factors, our non-modifiable and our modifiable, which are things you can do. I talked about the types of breast cancer, non-invasive versus invasive. Talked about screening measures, and don't forget your ultrasound if you have dense breasts. We talked about the different types of surgeries, and we talked about treatment options. Thank you.
All right, thank you so much, Dr. Rozell. I know there were a ton of questions that came in throughout your presentation. I kept track of all of them, so I promise we will address all of them. I wanted to, again, I keep using the word demystify, but I'm just so grateful that you explained so thoroughly what it looks like and what it means to go from the process of getting screened for breast cancer through treatment, because I think as we move towards hopefully getting more individuals to trust the medical community more and get more screening, information like this is just so critical. So thank you, thank you, thank you. We are going to introduce our final presenter of the evening, Miss Servelure Bostick, and I'm going to put her information up here for you all in just one moment. So Miss Servelure Bostick, she is part of our Sisters of Hope support group.
Yes, yes.
And she is an 11, Mike, do I have that right? An 11-year cancer survivor. And she is going to be sharing with us her story. And I'm just going to really let her take it from here. And thank you so much, Servelure.
Thank you so much, Kathleen. It's a pleasure to be with you this evening, ladies. I want to thank the Cancer Support Center for all the wonderful work you do. It's been a part of my life for 11 years. I remember going there one day to look at wigs, and certainly found my Sisters of Hope, which have been a lifeline to me through my cancer journey. So we've got a real serious issue in the South suburbs. I'm going to be brief because I'll tell you, we've heard some phenomenal information. We have experts on this panel, and I want us to have some time to hear from them. So I'm going to summarize real quickly my story. I thank the sisters for allowing me to share my story this evening. Cancer came into my life when I was a preteen, hearing that the grandmother that I was named after had died of female problems, if you will, at age 46. Back then, they didn't know the term gynecological cancer, so that's what happened to my grandmother at 46. At age 22, as I graduated from college, my own mother was diagnosed with breast cancer at age 46. She began her fight, and I began doing breast self-examinations in my 20s. She passed at age 50. Fast forward, my mother had two sisters. Both of them battled cancers. Her older sister was a two-time survivor of breast cancer, 25 years, and beat it. And then her younger sister succumbed to another cancer. So cancer has touched my life, touching all the women on my maternal, in my maternal birth line. So of course I was going to do everything I could to fight it, to end it there, to not let this generational curse continue with my family. So breast self-exams at 35, I cannot tell you how happy I was to have my first mammogram. I went running, skipping to have that mammogram. Because of my history, I got to have it early. And so I had mammograms from 35 on every year, religiously, as they would say. However, when I turned 51 and got married for the very first time, mind you, cancer showed up 4 months after getting married. I had a lump removed from my chest wall. I thank God that that lump was sticking, protruding out of my skin. And I had that removed right before my birthday. I remember the day we went to the doctor's office for the report. My new husband and I were on our way to the lakefront for a picnic, and the doctor said, "You have cancer." I'm like, okay. I had had a previous cancer, a skin cancer on my shoulder that apparently 10 years ago was cancer, had reoccurred in January, got it removed before the wedding. And so when he told me this lump in my chest was cancer, I assumed it was the same thing. He said, "No, this is real cancer." Those are the words he used. And then he said it is aggressive and advanced. So I was diagnosed with triple negative cancer. I left that doctor's appointment. We did not get to the lakefront. My doctor sent me to the hospital. That's pretty unusual, I want to say. I felt great. We had a picnic to go to, but we did not make it. So there began my cancer journey. there have been, I'm skipping forward, there have been a lot of ups and downs. I had the lumpectomy, I had radiation, 8 weeks of radiation, but one of the things that was unique, so many things were unique about my case, and of course everybody's case is different, but I can't tell you the number of doctors that were scratching heads and raising eyebrows and burrowing eyebrows when I would tell them things about my case, because it's really strange. But one of the things that was amazing to me is that I waited 7 months for chemotherapy that I needed. I had insurance. I remember that Christmas singing a song, all I want for Christmas is chemotherapy, chemotherapy. You all remember that song, all I want for Christmas is my 2 front teeth? All I wanted was chemotherapy. But I had a hysterectomy and I had to wait. It was April, 7 months later, before I started chemotherapy and then radiation. I have to say that the reason I am here is because of the grace of God. I'm simply a walking miracle. I've struggled with faith and fear like any other cancer patient. You start off with fear and then you put your big girl pants on and you get ready to fight. And so I'm a fighter. But God has been good to me because the survival rate for the cancer, my diagnosis was 13 months. I'm an 11-year and 1 month survivor, and 7 months for chemotherapy. It was all the grace of God. Nothing had grown, it had not expanded. So I say that to say to you ladies, if in fact you are diagnosed with breast cancer, it is no longer a death sentence. You've heard from doctors, you've heard from experts, from medical personnel, that there are clinical trials, there are always new avenues, continue research for fighting this disease. So don't run from it. You would not run from a person imagine a person following you late at night down the street, right? You hear the man in the movie that's following you and you start running faster, walking faster, and he starts walking faster. And then you start running and he starts running and the music plays louder and louder. Well, guess what? Eventually he's going to catch you. The way to combat that is to turn around and say, what do you want? Once you turn around and recognize who that is behind you, he'll leave you alone. So I say to you, don't run from it. If you're having pain, if something is going on in your breast, move forward. Don't sit still, don't stop, don't try to ignore it. Cancer will not wait on you. It did not care that I was a newlywed and I just got married. It will not wait on you. It will be inconvenient. So you need to fight. We have a problem in the South suburbs. Ladies, we need to fight. This webinar is called Kicking Cancer. Well, kicking is an aggressive action. When you kick somebody, you want to hurt them. Cancer is coming to kill, steal, and destroy you. You don't have to sit around and let it happen. The earlier you respond, the earlier you get tested, the earlier you go see a doctor, the better your chances, the more options you have. Have your daughters start checking their breasts in their 20s. I didn't have a BRCA gene. With all that family history, I don't have the BRCA gene. My cancer isn't hereditary, at least not at this point. So don't say it doesn't run in my family. It doesn't work, not an excuse anymore. You have to take care of yourselves. Don't let finances keep you from moving forward. Don't let fear keep you from moving forward. If you get that diagnosis, I want you to know that the Sisters of Hope at the Cancer Support Center in Homewood and in Mokina, the Cancer Support Center is in Mokina as well. The Cancer Support Center is there to help you and to support you. Don't think you have to do it alone. So with that, I'm going to stop because I want to have some time we don't have a lot of time to answer a few questions. Thank you so much.
Oh gosh, just thank you so much. Your spirit is infectious, and I just know, I don't know if you could see the comments coming in while you were speaking, but there was just a whole lot of amens, a whole lot of exclamation points, and a lot of support for everything that you were sharing with us. We're so grateful. And like you said, I know we don't have a ton of time left, but we do have some questions to get to. And so I was doing my best to keep track throughout the comments. There were a few things that came up about one part that was really interesting is like, what about having different screening guidelines for Black women?
Well, that's again why I say I think we should be getting it done earlier. And I think it's not just in breast cancer, it's a lot of cancers. You look at colon cancer, all these different things where we have a higher risk of mortality. So I am emphasizing usually at 40, and I continue it on as long as the patient is in pretty good shape. I don't stop.
Thank you. There were a few just kind of scientific things that came in. Just how many lymph nodes are under each arm?
There are hundreds. That's not a decisive number. Remember, I said it's like a river. So there are tons. You know, we have lymph nodes all over the body. So, you know, even removing 20, it's, you know, and if something is discovered under the sentinel and you do a dissection and they take out 20, that does not mean that there's no others remaining in the underneath the arm that are positive. And that is the main reason why I'm actually recommending chemotherapy, because you're trying to prevent these tiny cells, these cancer cells, almost like sand, from floating and traveling to other parts of the body.
Thank you so much. Dr. Burress and Servelure, could either of you and Dr. Rozell speak to just how do you decide when to go back to work? That's something that came up a few times early on in the presentation.
So since I emphasize it, I can start. I think it's important to have a support network. So whether it's family members, girlfriends, or being part of organizations like Sisters for Hope, you need that village. You know, they say it takes a village to raise a child. It takes a village to help folks through this process. So again, looking back on my journey, I wish that I had not have returned to work so quickly, but in hindsight, can I make that rational decision when you're in the midst of it, you know, and trying to juggle so many responsibilities? I think that's what changed the course for me. But if I could do it all over again, I would definitely delay my return to work.
How about for you, Servelure? Was that something that you experienced?
I actually didn't have much of an issue with returning to work from the cancer surgery because it was a lump removed from my chest wall. The only time I was out from work was for the hysterectomy. So not an issue for me. But I think it's important to not only look at listen to your body, but to look at your home situation as well, because if you have to take care of home and family, and then you have to go to work, that's another responsibility. So you have to look at your the totality of your lifestyle.
Mm-hmm. Yeah, absolutely. Dr. Rozell and Dr. Burress, there were a couple of questions that came in ahead of time too. One was, does grade 3 mean stage 3 cancer?
No. Grade 3 is, what does it mean when you're looking at the slide? So grade 1, for instance, means that your cancer looks like normal breast tissue. Grade 2 means it looks in between. Some of it looks a little funky like cancer. Some of it looks like normal breast tissue. And grade 3 simply means it looks like cancer. So grade 3 is not stage 3.
Okay, and could either of you speak to lymphedema really quickly? We have a question come in, just is it normal to get it after surgery, and do the areas under your arms go back to normal?
So remember, when you get the surgery or you have this mapping when there's a river, you have now disrupted the normal flow of the river, okay, when you actually have done surgery. What I know is patients who do a mastectomy, or you have what's called the axillary lymph node dissection with more than 20 lymph nodes, think about it, you have really disrupted that river, so you will get lymphedema. Those who have a lumpectomy, less likely, but it's still a possibility. You know, I recommend, again, pretty early, making sure that you're wearing the sleeve. We also have a program with Tactile where they actually use a machine to kind of start squeezing and mobilizing that arm and trying to get those lymph nodes to actually improve. So it's a big problem, but I think we're doing better, but I still have patients who complain about it.
Mm-hmm. There's a question that just came in from a woman. She's 32 and her mother was 54 when she's diagnosed and died at 60. Should she start get genetic testing now or try to get mammograms now?
So I think it's a little complicated. I need to know what type of breast cancer her mom actually had. Mm-hmm. Also, if there's any family history of any other cancers. And that will kind of help determine whether or not she actually is eligible for genetic testing. So I think it's really individualized.
Okay. Thank you. Anything else? Anyone on the line? We have just about 1 more minute if anyone wanted to unmute and ask a question before we close out for the evening.
I have a question. Can I ask it right quick?
Sure.
So I want to ask the doctor. So in the beginning, I was diagnosed last October with triple negative breast cancer. I had my surgery and all of my treatment done at Northwestern. I worked there. After my surgery, I guess they do like a final path where they run. And I was told that it changed from triple negative to ER negative and HER2 positive by a fish. How often does that happen?
So that's what we call discordance. It's usually about 5%. 5% of the time you can have a change. And so for instance, I do that a lot on my patients who actually progress. So for instance, if the cancer has progressed and they may have been hormone positive, and now all of a sudden I had them on a medication or a pill, and now the breast or the cancer is getting larger, I will actually take another biopsy or sample and see if it's concordant, meaning it's still the same, or if it's discordant, meaning it's changed. And a lot of times these cancers do change. So it's about 5% of the time.
Okay. One other quick question. I'm sorry. So I have two daughters also, and they're in their 20s. When I did my genetics testing, I was BRCA negative. I've been telling them, should they still get like tested for BRCA?
No. So if you were negative, the likelihood that they're negative is pretty much 100%. What I would suggest is, I don't know how extensive your genetic panel was. So the question was, did they just do BRCA mutations, or did they check everything? Because there are other mutations that we are learning about that are predisposing us to developing breast cancer. So say, for instance, if I seen a patient in 2009 and they only did a 16-panel gene, and now we've come up with a 50-panel gene, I may say, hey, come see me. Let's run the more extensive panel to see if you do have a new development of a mutation that is also causing breast cancer, because it's not just BRCA 1 and 2.
Okay.
I had a question about estrogen positive. So if you're only estrogen positive, is there a change in survival rate when you don't have the other two?
So you're estrogen positive, progesterone negative?
Yep, and HER2 negative.
So usually estrogen positive, again, that is more favorable. But as we know, as you start losing the other hormones, so progesterone negative, it's a little bit worse than someone who is estrogen positive, progesterone positive.
Okay.
Yeah.
So it's just requires pills. I mean, more.
At this point, it depends on if you had the oncotype or that testing done to see what is your risk of this cancer coming back. And you should have, if you've gotten it done.
I had a double mastectomy immediately, and I'm doing 2 rounds of chemo and radiation.
Okay. So, but did they do the high risk testing, the oncotype?
They did not do the testing because I wasn't tested. I wasn't in the risk factors that required it, but I can always go back and ask for it.
Okay. Did you have lymph node involvement?
They took out 20 lymph nodes and only 3 had a small spot in them.
Okay. So if three were positive, then that's the reason why they argue for chemotherapy, because it's usually 0 lymph nodes positive, or maybe 1 that is positive. That's when we decide whether to do the test.
Mm-hmm.
I think we could certainly have a follow-up with probably just genetic testing as well. It really is such a rich topic. And yes, it's so interesting, and there's just so much that we still don't know and that we should learn. I just wanted to really quickly, before we close out tonight, post up these free mammogram resources. So if anyone in your life, in your community is in need of free mammograms, please, we have the resources. I will definitely be able to email this out to everyone as well. And just our next steps are, just for anyone, I know a lot of our attendees tonight have gotten screened, have been dealing with breast cancer. For anyone who hasn't, please get screened. Use the links we provided. Reach out to us. We're going to be doing screenings in our local communities as well. And just reach out, because we're really here to remove as many barriers as we can for anyone who is dealing with any type of cancer. And so please just don't hesitate to give us a call, email us. We are here for you. And again, I just want to give a huge shout out to our presenters this evening, Dr. Burress, Dr. Rozell, and Servelure Bostick. Thank you so, so much. We could not have done this without you, and we are just so grateful. So I know we had a request for a standing ovation. So if anyone feels, So moved. I just really thank you so much. This was thank you. And please don't hesitate to reach out if you need anything else after this. We're happy to continue answering questions, and just have a wonderful evening, everyone.
Thank you.
Take care.